Hello and welcome to my talk on predicting patient outcomes with graph representation learning. I'm Emma Rocheteau, a PhD student in computer science and formerly a medical student at Cambridge. This is work in collaboration with Catherine Tong in Oxford and our respective PhD supervisors Pietro Leo and Nick Lane, as well as Petar Velichkovic, who now works at DeepMind. So just to introduce the electronic health record in the ICU, this contains a range of data collected by health professionals about their patients. Our work focuses on how to use one particular aspect more effectively, the diagnoses. Diagnoses are a rich source of information for the clinician. They immediately tell the doctor what kind of treatment that the patient is probably on, and it'll give an indication on the patient's likely outcomes, for example, whether they're likely to die and when they might be discharged from the hospital. The problem for machine learning is that they're tricky to use effectively. Typically, there are a huge number of possible diagnoses a patient could have, and each patient will only have a small number of these, meaning that the data is very sparse. This can be imagined as a very long vector for each patient, where only a handful of positions are equal to 1, and all the others are equal to 0. This means that many patients have a unique pattern, and it can be difficult for the model to work out which signatures are important and how to relate this back to the outcomes. Many diagnoses only have a few instances, which means that the model is going to struggle to learn anything useful from the rare diagnoses. This is shown by the distribution of the frequency of each diagnosis in our dataset, the EICU database. The red dashed line shows the mean frequency, which is actually 229 instances, which isn't enough for most deep learning algorithms to learn something meaningful. The typical approach would be to choose some sort of cutoff value for inclusion so that only the common diseases like diabetes, heart failure would make it into that vector. And they might apply an encoder layer or two to reduce the representation size before it's fed into the model at a late stage. Unfortunately, this throws away a lot of valuable information. So in order to preserve this information better, we took some inspiration from how doctors solved the problem. So how do they learn from the rare patient cases? Well, one way that doctors do this is by recalling their experiences of treating rare cases in the past. But notice how this is in a more direct way than a typical deep learning model remembers its training data. The clinician will actively compare how this new patient is similar and different from those past experiences, and how that might inform their view of the current patient. This is something that we try to emulate with our model architecture. Specifically, we draw links between patients that are similar to each other and allow the model to see data from those similar patients as it makes a prediction about the current patient, which allows the model to see that patient in context, as would the clinician. So the architectures that we use are called graph neural networks. They take a graph as their input. So just to quickly summarize how this works, you give the network a patient. So this is denoted by the node colored in pink on the left diagram. The GNN will transform the data in some way before aggregating between similar patients, which are shown in purple. And this leads to a new representation of the patient, which is shown on the right in green. And this then can be used in downstream prediction tasks such as length of stay or mortality prediction. So now that we see how we can use our approach, we need to go back to how do we construct the patient similarity graph in the first place. So we tried a few different ways of doing this, but the method shown on this slide was found to work best in our experiments. So we start with the disease matrix or diagnosis matrix shown by capital D here. And this has dimensions n times m, where n is the number of patients and m is the number of unique diagnoses. Then we have lowercase d mu, which represents the frequency of diagnosis mu. And also we have a couple of constants, a and c. So if you go up to equation 1 here, the first term in our equation calculates a score for the shared diagnoses between the patients. So since d is n times m, di mu will indicate whether patient I has diagnosis mu. And if di mu and dj mu are both equal to 1, then it means that they share a diagnosis mu. And the multiplication will then give us 1 if both are equal to 1, and any other combination will give us 0. So then we multiply that by the term inverse d mu plus c. So the point of this term is to place more emphasis on sharing rare diagnoses rather than common ones. So d mu is the frequency of diagnosis mu. So the inverse would give us a rareness statistic, and then we add c to ensure that a diagnosis, no matter how common, will always contribute a certain amount to the score. And then we do a summation over all the diagnoses that they might share. And then we have a second term, which penalizes the score for the total number of diagnoses that are present across patients I and J. And we added this because we noticed that patients with lots of diagnoses were forming large hubs. And because they're more likely to share diagnoses with all the other patients, they were forming these hubs, but the matches were non-specific because a lot of the diagnoses weren't shared between the patients in the match. So we added this term to penalize having lots of non-shared diagnoses between the patients. And notice how we add a parameter A to weight how much we care about positively upregulating shared diagnoses compared with penalizing the non-shared diagnoses. And then once we have those scores, we can then use k nearest neighbours to choose the matches for each patient. And then we optimize k as a hyperparameter of our pre-processing. And I think we ended up finding k equals 3 to work best. So this figure summarizes all of our steps. So step 1 is to make a patient graph. Done by scoring the similarity between each patient pair and then selecting the highest scores to draw the edges in our graph. And this is a pre-processing step. And then at the modeling stage, starting from step 2, we randomly select a patient to make a prediction on, and we take this patient and their neighboring patients. Each patient has both time series data and static data associated with their ICU stay. So we obtain an embedding of the time series using an LSTM model. So this is things like heart rates and blood pressures. And this is shown in step 2. And then we allow the sharing of that LSTM embedding in step 3. So there's a transfer of information along the edges of these of this graph. And this is the graph neural network step. Once we have this enriched representation, we also process the static data in step 4 using a fully connected layer. And then we concatenate all of the representations together in step 5 and use that to predict the label, which is either length of stay or mortality. So this is a small section of our results. Along the bottom, we're showing an LSTM star model, which doesn't have access to any diagnosis information. So this only takes in the time series and the static data like age and gender, and there's no sharing between patients. And then we have a second baseline, which is the LSTM with diagnoses presented in the traditional way, meaning that long diagnosis vector I talked about at the start with a couple of encoder layers. And then the next 3 are different types of GNN. So we have Graph, SAGE, GATS, and MPNN. And these are all slightly different in how they transform and aggregate the data, but the principle is always the same. So they share data between similar patients to obtain a better representation of the current patient. So in red on the left, I'm showing the mean absolute deviation, which is a metric for the length of stay prediction task. For this metric, lower is better. So first of all, we can see that by including the diagnoses as a long vector, we see a modest improvement in the results. But when we represent the diagnosis information as a graph, we obtain significantly better results. And there's a steep drop off here. And then in blue on the right, I'm showing the area under the precision recall curve as a metric for the mortality results. So for this, higher is better. So we can see that the biggest benefit is from providing the diagnoses information in the traditional way. So this is probably because there's certain common diagnoses in the ICU which are very predictive of mortality, things like sepsis, and a lot of this can be captured by the simpler method. But when it comes to a more nuanced task like length of stay, we really see the benefit of providing the diagnosis in context of similar patients. And this is just a small section of our results, so please see the full paper for ablations and variations. The final thing I'm going to talk about are the interpretability benefits of one particular model that we tried, the LSTM-GATT. This model attributes attention weights to edges in the graph. So the patient in question here is the one in red. So he's a 67-year-old man who's just had lumbar spinal surgery and has a background of hypertension, congestive heart failure, and has a pacemaker. So usually surgical patients would stay less time in the ICU, and they're usually healthier than medical patients because you have to be deemed well enough to have had an operation. However, if you ask a clinician which diagnosis is most pertinent for the outcome prediction task with this patient, they'd probably say the congestive heart failure because it has a poor survival beyond 1 year and it's a common cause of extended length of stay. Now, if we look at the other patients that our scoring system has identified, all 3 patients have had the same surgery as the one in red. But the 66-year-old man in blue also has a bunch of cardiovascular conditions, and most importantly, including congestive heart failure, as well as some diabetes. And the other 2 neighboring patients don't have heart failure, just hypertension. So the attention weights attributed by the model are shown by the thickness of the lines in this diagram. So we can see that the model pays most attention to the self edge, followed by the patient in blue, who is most similar clinically. And then we have the older patient in green, and finally the younger female patient in yellow as the least relevant. So this is a nice consequence of the model because it can provide some verification to the clinician that the model is working as intended. Thank you so much for listening, and I'd be delighted to take any questions. Thank you.